Thank you very much. So I'm talking about complete dentures today, and these are the 7 pillars which I touched on yesterday, so we're going to explore this in a bit more detail. Let's have a look at David here. So I'm going to take David's denture out here. I promise you there's no implants underneath this denture. So it has really good grip, and I want to show you exactly how I did that today. So I actually learned this particular method from Dr. Abe, who's based in Japan, and Rowan and I went over to visit them almost 4 years ago, and this is his technician, and he's written a terrific textbook on this particular technique. It was published in 2010. And it's really like a Haynes manual of how to produce a suction lower denture. It's really very, very good. And Rowan and I have actually used this technique for about 4 years. We've adapted it slightly to our technique, so I'm going to describe that today. So I'm going to jump straight in and show you how to do that on the lower denture. But before I actually do that, I just want to really emphasize I only get suction like this on 20% of my lower cases. So I don't want you to go away thinking, right, I'm going to be able to do this straight away and get really good results on all of the patients, because it's totally impossible. There's certain features that the patient needs to have in order to get really good suction. And 2 of those are really nice, decent ridges, and also plenty of soft tissue in the lingual sulcus. So this is Joyce here. I've managed to get good suction for her. So let's just dive in and look at this. So in order to do that, I need to take a really good primary impression, and I use this specific tray. It's a stock tray. It's produced in Japan. It's produced by Morita. It's designed by Dr. Abe, and it is absolutely superb for this whole process. It's cut away at the back, so the retromolar pad is free. So I'll show you that in the mouth here. You can see that there. The retromolar pad actually pokes through, but down the retromylohyoid area, it extends into that bit. And then we use this impression material, which is a 2-part alginate, and there's a thick bit that goes in the tray and a runny bit that we put into the sulcus, and I'll show you exactly how I do that just now. And I want to record a massive primary impression. It's really overextended in order to produce a special tray, and it's a special tray that helps to produce the suction. So here we go. So I'll just set the scene here for you. This is the surgery. This is Claire here. Claire is mixing the runny impression material in here, the low viscosity alginate. She's going to load that syringe. I'm actually mixing here the thicker viscosity material and loading the tray. So here we are working. Claire's putting that into the large syringe. We've got Mary waiting in the chair. I'm loading that tray, and then I'll just run my hand on some water and glaze the surface and shape it up. And then I come over to the patient, I pop the tray down on the side, and then Claire stands behind the patient. This is a pretend dental chair here, patient in the chair. She pulls the lip forward here, and it allows me to get access to the patient's mouth. And in addition, I use a knee brake chair so that the patient's feet and legs are not getting in the way of me. And I really like that aspect, so I can actually sit and almost kneel in front of the patient and do this. So Claire holds that forward. I pick up the syringe from the side, and I get the patient just to totally relax the mouth. Relax. And then squirt that right in underneath the tongue, all the way round the lingual sulcus, over the top, right into the buccal sulcus, all the way round. And then I pop that on one side. And then I pick up my stock tray, and it's almost like that Mr. Whippy ice cream, that thick ice cream. Just rotate it in and over. Looking at the lower anterior ridge, I line it up with the lower ridge, push it down, and then get the patient just to put the tongue forward and then count to 5. 1, 2, 3, 4, 5, and the tongue's relaxed, and I push it back and down, and then I give the cheek a massage. I get the patient to close together and I massage the cheeks just so I get the actual buccal border of the mandible. So, and it comes out like this, and it's really quite a predictable technique. It works really well. But I think the secret to this, to actually doing it, is to rehearse it first with the patient without actually putting the impression material in. So actually, we go through that whole process. We do a proper dress rehearsal, a dry run, without the impression material. So I'm not actually just coming in and going wham into the patient and they're all tensed up and nervous. They know exactly what's going to happen. And it's all about relax your mouth. And I never mention the word tongue, because as soon as I mention the word relax your tongue, it becomes massive and grows. It's just relax the mouth. So Rowan paused this, and this is always a very big model here. And I just want, this next sequence is actually the most critical part of the whole talk today, and it's about designing the special tray. So designing the special tray, it's really crucial. So first of all, number one, I actually draw around where the retromolar pad is, do a circle on that, and also I put in a little bit, this little line there, that's a sinew. Let's have a look in the mouth. This is what Dr. Arbate introduced me to. There's a sinew at the base of the retromolar pad that runs, it's part of the buccinator, and it attaches into the base of the retromolar pad. The denture, I must avoid that area and sweep in. So if we look at the design of the tray that we're going to do, it sweeps in at the base of the retromolar pad, just there. So we are avoiding this sinew that sticks in there. I then draw a line here which is 2 millimeters short of the width of the sulcus, and this is going to allow my green stick and and zinc oxide, my green stick, to mould in that area. Avoid this frenum here in the premolar region, and then I take it 2 millimeters short of the depth of the sulcus just here. So next, on the inside, it's really important. So this is lingual. So right in the center, the middle of the retromolar pad, I draw a vertical line right down and draw it down to the mylohyoid line, to this point here, which is where the sublingual gland comes up. It's about the fore region. I draw a second line behind that, which is 2 millimeters behind, and draw that all the way around and converge it into this point here where the sublingual gland is. Next, I draw another line, or continue it further forward, just on the lingual aspect of the lingual shelf of the mandible. And then I do exactly the same on the other side. So, and we've been doing this for such a long time now. Rowan does this automatically for me, but if you're going to be doing this in practice, what I recommend is get that primary cast back, draw it yourself, and then get the technician to make the tray to that. So Rowan makes the tray to the outside of that line and avoids that undercut, under where you got the mylohyoid line, down into the depth underneath that. We don't take the tray into that. He blocks that out. That's really important. So this is this is in handouts. You can get that from me. But if you want to take a photograph of that, that literally summarises exact those steps that I've just taken you through there. Okay. So do you want to have that up again? Sorry. So next, I want to do my border moulding, and I just love using green stick. It's a Kerr product. It's great because I can reheat it and put it back into the mouth. Now, most of you probably, will be thinking, flipping heck, was taught this at dental school, it's just awful stuff. It's like heating it over the Bunsen, you've got this snake of thing, it's dripping everywhere, it's a real mess. So, but I use a totally different method to this, a much simpler way. So this is the surgery here. I'll just set the scene here. We've got a kidney dish here. In that kidney dish is hot water, just running from the tap. It's hotter than 50 degrees C. In there is a stick of green stick. I've got some Vaseline on my gloves, so it's not going to stick to my gloves. The hot water melts the green stick. I've got my special tray here, and I've also got a Bunsen in the surgery too. So I'll show you how it's done. So what I do is I heat up the border of the tray in the Bunsen, so it's really hot, and then I get a thick earthworm of green stick, stick it on the side. So I know the first part I do is the buccal shelves, so it's from about the 7 to the 4, just on that buccal edge. So, and I do both sides, so I'll warm it up in the flame. It really heats up the tray and it allows that green stick to stick properly, and it doesn't come off when I'm actually doing my border moulding. And then once I've put that on, and it's not on the fitting surface, it's just on the outside, it's like a polished surface thing really. And then I put that back into the hot water, and then I take it to the mouth and get the patient to go ee and ooh. But I'll show you all of that amalgamated together when I actually do the impression with zinc oxide in a minute. So I do it on the buccal aspect, so from about the 3, 4 to the 7, avoiding the retromolar pads completely with green stick, and then lingually all the way around that lingual surface. And I do these particular movements. And then I do the same movements when I put my zinc oxide into the impression tray. So it's 6 movements, and I'll take you through that just now with a video. So I've got the patient in, we've rehearsed it, Claire's got the thing forward, pulling the lip forward. I've got the tray here ready to go in, and you can rotate it in and down. And often what I'm doing is I'm actually kneeling down in front of the patient, just push it down properly. Right back down. This is a close fitting special tray, by the way. Down, and get the patient to close up and go woo, ee, and then open wide, and then close, almost to biting together. Lick the lip, really go for it, licking the lip. Push against that lower front strut, which is like the lower front teeth with the tongue, and then have a really good powerful swallow. And if you notice, Claire got the 3-in-1 tip and squirted it in the mouth just before the patient did the swallow, and it just helps them to actually do that. The powerful swallow is absolutely key to this. So it's basically functional movements the patient will make during their everyday life. And it comes out like this. It's a bit like a polished surface. We've got all these lovely polished surfaces ready for the denture to be made. So we have this shape here, and then Rowan really carefully duplicates that and copies that in the actual final product. And that's the key to it. It's as simple as that. So now, uppers. This is John here. I'm going to try and take John's upper full denture out just now. So I can really pull on that. You know, really pulling down. But if I lift the lip up, the seal that's formed by the lip just breaks that seal, and it can just drop down. So, and this is what I want all of my complete dentures to do. Even if the patient's got a really flat maxilla, I still want that suction on it. And it was my friend Fraser McCord, that taught me how to do this years ago, 20 years ago. And it's very straightforward. I'll show you how I do it. So it's the same system as the 2-part alginate for the primary impression. So I've got a runny material which I squirt into the sulcus all the way round. So I'm making sure, and I can just kneel down and do this. It's great, particularly with Claire with these little retractors all the way around. and then I have my thicker material in this is just like a standard edentulous stock tray. Rotate that in. The patient's sitting up, so it's not going to fall down the throat, but I try and seat it at the back first, and then rotate it forwards, up. And then I get Claire to take the retractors out, and then I gently just push on the lip here, just to push the impression material up into the sulcus. But it's an overextended impression again. I want it right beyond the tuberosities and the full depth of the sulcus impression. And it comes out like this. It's really very predictable. It's lovely. I find it much better than compound, which I used to use. So Rowan then makes a special tray on this, and it's very simple. The upper special tray is spaced because I'm going to use alginate, and it's 2 millimeters short the depth of the sulcus all the way round in that labial sulcus and buccal sulcus, just a little bit further back than the fovea palatini on the posterior border. And this is a special tray design. The lower I have 3 handles. On the upper it's just got 1 handle at the front there, and it just stays away from the lips and from the tongue. And I can just pop that in. So this is spaced. So in order to recreate the space that Rowan's used to make the tray, I put some green stick on the fitting surface. So there's 3 areas. At the front, on the canines, particularly if that tissue is nice and firm, and then across the posterior border at the back on the actual fitting surface. It doesn't overhang the back, it's on the back, and I push it in. I push that up into the mouth when the green stick is soft, and then I have a look here to see if it's overextended. If it's pushing up into that sulcus and bouncing on the curve there of the soft tissue, if it actually pushes there, I'll just draw it with a China graph pencil, take it to the lab, grind that off, and then pop it back into the mouth, and make sure, you can see, I want to have a good gap between the depth of the sulcus and the tray to allow the impression material to really form that lovely functional sulcus. So once I've done the fitting surface, it's now the buccal bits, and it's really important. I don't put any at the front at all. I want that kept free, so I've got a lovely thin flange in the denture to support the lip properly. I just put it from about the canine backwards and pucker out that green stick in those buccal areas. So it's nice and soft, goes back into the mouth. I mould it myself, get the patient to waggle their jaw, and also open really wide. So it's just the coronoid process is actually narrowing that there, and it comes out like this. It just changes from that big puckered out bit to in. It's the width that's really important with this. So now it's time to actually do the definitive impression. So I put adhesive on the tray all over. I don't perforate it, just put a load of adhesive for alginate. And I like using Dentsply Blueprint for this, and I mix it up really runny. So it's a really thin mix, not very much, and I glaze it with water just to reduce the air bubbles. It just produces a lovely smooth surface. Take this to the mouth. So here's Joyce. So we're all set up. Claire's got the lips forward. I'm just going to put it in, rotate it in, and push it up at the back first, and then rotate it forwards there so it's not running down the throat. Ask Claire just to gently take those retractors out. If we come round to the front here, this is a different patient. This is Ellen. So it's in place there, and this is what I do. So I hold it in, push it right down onto my green stick stops firmly, back down, and then mould the cheek and pull it right down, trim that, mould the other cheek by pulling, and often I have to make sure I take the Vaseline off my gloves because they're a bit slippy after using the green stick. Okay. And then just make sure it's nice and narrow there. Waggle the jaw. Coronoid process is actually moulding the alginate beautifully.
And then can you suck my finger?
And then I suck my finger, the final thing. But you can just look at a modiolus there, it's really moulding it. And it looks great afterwards. I can just lift the lip up and have a look. And I've got this lovely border here, which is, so we've got the edge of the tray and about 2 millimeters have gone in, and she's moulded all that beautifully for us. And that's what we want to finish the denture to that functional edge. And often it's not a problem if the green stick's showing through. In fact, if the green stick is showing through on the fitting surface, it's better. It means I've pushed it down properly back onto my stops. So Rowan carefully duplicates that in the final denture. So, and this is the heart of the lab. This is just another of the pillars. It's just so important having a great technician. I'm so fortunate having Rowan in the room next door. We've grown and learned together over the years. I worked with Rowan for 20 years. It's terrific. And the lab's literally, we've got a door that opens from my surgery into the lab, and it's just wonderful. And all of the work that you'll see is his. He's absolutely fantastic. So the next pillar really is about these photographs. I want the patient to bring in as many dentate pictures as they possibly can. It doesn't matter if they're not smiling. It just shows us so. Look at that photo there. Isn't that brilliant? Great lip support on Ernest here. When he was in the RAF, in the war, flying out of Italy. Here he is, 1940s. And he came in looking like this. And it's just, he's got no neuromuscular control. That denture's just dropping down. It's just awful. But he brought in this lovely picture as well here. This is on his wedding day, with this beautiful arrangement of teeth. And that enables Rowan to really copy this and make it age appropriate. And he wanted to have age appropriate teeth that looked like, flipping out, if someone met Ernest, it'd be like, gosh, Ernest, you're lucky to have kept your teeth at the age of 89. So, and we've put, amalgams in and cracks and stains, but really, it's really about looking at the photo and trying to copy that detail. And, looking from underneath, this is the full upper that Rowan did for him. You can really see the movement of those teeth. And we've even kept a missing premolar up here as well. It's just really, just thinking, being brave with it really. And it just produces a lovely result, for the patient, much nicer, and also functionally works really well. So, how do we achieve that? The key to getting the tooth positions in the right place is all about me carving that wax rim. I've got to do that and give Rowan the information to then set up the teeth. It's just a matrix for him to set it up with. And it's all about, looking at the photo and then carving this. So with Henry, that's Henry on his wedding day there. Look at that. Great buccal corridors on him. So we've got to, copy this. So now, in order for me to do this, it's absolutely important this upper stays in place during this visit. So we're at visit 3 now, so we've done our definitive impressions, we've got our definitive models. If I put the wax rim in and it drops down, I can't do this carving, it's just hopeless. So if it does drop down, I carve a post stamp at that particular point now. So I'm going to show you how to do that. Now, this is how I do it. So I look on here, and if you look closely, you can see the fovea palatini just here. I've just highlighted them in those black dots there. And then I draw a line all the way back. So right through the fovea, all the way back round the tuberosities. And then it's a bit like a Cupid's bow, so I'll carve these other bits in here, and I'll show you that just exactly how I do this. So I draw it first. I've got a picture of the Cupid's bow there, so we've got the lips together, and then that lovely curve of the upper lip there, and I draw it on the model. So you can see this is a definitive cast, and you can actually see the old post-down position of the previous denture. So this is going further back. If I take it further back, we get much better suction on this. And I draw on exactly where I want the post-down to be. Just like that. So, and I soak the model then just in water, because like this is a stone model and it's really hard. Soak it in water and then scrape it with a Lacron. This is speeded up 4 times, but it just shows you what I'm doing. I just cut it right in and get that back bit, the back line, nice and deep. So it's 1 millimetre in the outside bit where the connective tissue is, and it's about 0.5 millimetre further forward, but I'll show you a picture just in a minute. Once I've carved that, I warm up the posterior border of the wax rim and push it into the post dam, and that forms a seal for me. But this is quite a useful photograph if you want to. This shows like the depths of what I'm trying to do. So between these blue lines here, it's about 1 millimetre deep. I cut the model. Coming through the centre section there, it's not quite as deep, it's about 0.5 millimetre because we've got a really hard palate there and not much spongy tissue. So, and that's how I do it. And it's deeper at the back, and then it's a bit, so this is your deep end of the swimming pool. Deep end of the swimming pool, and that goes to the shallow end, just here. And that pushes into the tissues and holds it in place. And then we then put the rim in and do all of this, and it's like a carry-on film, going really fast. So, and it's very much me and Claire working, looking at the patient, and we carve the rim in this set particular order. So it's lip support first, incisor plane relative to the picture, because I've got a lovely photo of the patient with dentate picture there, and I want to try and really imagine what Olga's going to look like if she had a natural teeth at this present moment in time. So it's lip support, incisor plane, occlusal plane, which is, the occlusal plane is parallel to the ala tragus. You can see I'm looking at that here on this video. We've got a fox's bite plane on the rim, and I've also got a ruler looking at it to check it's parallel with the ala tragus, and that produces this lovely aesthetic result with the dentures. And then I mark on there where the centre line is too. And then 6, I actually look at the occlusal vertical dimension. And if you notice, the lower rim looks a bit different. It's not a full block, it's a pivot or a Manchester rim. And it's got 2 bits. So we've got, actually, the blocks of wax go from the 4 to the 7. And it's much easier just to trim that quickly to get it to marry up. But it's purely for the occlusal vertical dimension. And the way that I assess the occlusal vertical dimension is, if it looks right, then I stay with that. And actually, there's no hard evidence to show how we can actually assess the occlusal vertical dimension if it is correct. So John Coyce uses this method of, if it looks right, then we feel it's right. And I do find that's pretty good. It's really just really looking at the patient. How do you look with those rims in and walking around? So it's literally assessing it visually. And if we have a photo like this, it's terrific. You know, look at that. I wouldn't, in a month of Sundays, copy that sort of design here. And that's what we did for David. You know, we set those back, dominant canines. You know, it just is quite different than I would have done if I didn't have that photograph to work from. It's lovely. And this is the denture itself. So when Rowan is setting it up, he really has to be brave with his tooth positions, and those lateral incisors, get them back. And you know, where he'd normally have the canines just tipping in a little bit, he's made them dominant. He just literally copied the photograph, really, of the patient. So, right, someone yesterday asked about how do we calculate tooth sizes. I think it was you here. So this is just for you. And it's great, actually. I love it. I use this all of the time. It really is a super method. If we have a really good dentate picture of the patient here, and if it's above the age of 8, because our interpupillary distance from the age of 8 upwards remains the same for the rest of our life. It's a stable reference position, so 8 and above. So we've got Jen here, we've got There she is in the chair with her old denture in. So I know that her interpupillary distance is the same. And if I click on, I can take these measurements. So I can measure her interpupillary distance on the photograph, which I've enlarged and put on the screen. So I'll measure that. A photo PD, the photographic width of the upper central incisors, and I've also got the patient sitting in the chair. I can just measure the interpupillary distance there, plug it into this formula up at the top there, and it will give us the true width of the upper central incisors. It's a really neat formula. It's lovely. It's just a ratio. Very, very simple. And from this, we calculated that the two upper central incisors would be around about 16.7 millimetres. And so if we divide that by 2, one central incisor would be 8.4 millimetres. So in terms of research, the average upper central incisor is between 8.9 and 9.2 on average. So this is slightly small, but we do get ranges of teeth. So once I know what size that tooth is, then I need to select the right shape. So, and usually we have 3 potential options. So there will be about 3 options of upper centrals that are about 8.5 millimetres. So we find all of those of that size and get them out. There. So Rowan and I just get them out, and we don't let the patient participate with this. It's just not their bag. How can they tell what that's going to look like in someone's mouth, you know? So we just do it. So Rowan will go through to the lab, he'll get 3 of these out. You can actually get this for your surgery, a chair side, which is really useful to get. But he'll select 3, and then we'll really look at the photo here and carefully think, okay, so we think they look a little bit like IT, it's triangular. T means triangular shape there. And we just select the ones that we think are the closest to it. So that's the ones that we chose for Jen here. And that's what we did for her. You know, we took her from having this to this, you know, mimicking her photograph. So Rowan's kicked out that upper left central incisor. Upper left lateral incisor, the upper left central's knocked back a little bit. It's just we're playing with that, and we've looked at the buccal corridors on the photographs, and the way that we carve it in those 5 things will help to produce that lovely curve, following the curve of the lower lip. It just works like a recipe. It's great. The other thing that screams a lower denture is straight lower front teeth. You know, and they're absolutely perfect, because when patients get older, they show that sort of thing. They show the lower teeth more than the uppers. And if they're absolutely dead straight, it just looks like a denture. It's horrible. And we've got Bert here. This is a chap I showed yesterday. And so Rowan's made his lowers a little bit wonky, and it just looks really nice when you're chatting with him. I don't want to think it's a denture when I'm talking to him myself. So next, really important, patient acceptance, trying videos. So here we've got Diane. Now, Diane came in with these 2 dentures here, and this was an immediate denture that she'd had provided by a dentist, and then she'd had this one done by another dentist, which she was much happier with in terms of comfort, but she just wasn't happy with the appearance of it. And I'll explain why just in a minute. So here's Diane with her, she brought in loads of dentate pictures, and she's got this really sort of like big overjet, almost like an AOB really. And so this is what we did for her. So this is the trying in place. That's the trying that we did for her. So she's got a full upper, she's dentate lower, she's got a natural dentition in the lower. And so we do this video, and it's really important. doing prosthetics is really quite relaxed because it's not particularly invasive type of dentistry, it's quite sociable. And I'm often pottering about doing stuff and Claire's chatting to the patient. So they're really relaxed when they come into the practice. So we get them on the chair, Claire has a tripod here with the video and just has a chat with them. Socially interacts. And so Diane hated this, really didn't like the look of it. And the reason that she said, I look dead with this in. And she said, when I had my natural teeth, I used to be walking down the street and my face would just be at rest, but people would think I was smiling. And she wanted to have that look back. She wanted them further forward and more dominant. So when she looked at the video, it was no way. And she'd go, oh, they're just not where they used to be. So we changed it to this. So we did another try-in. 2 weeks later, got her back in, and this was it. We really brought them right forwards, much more lip support, and incompetent lips, essentially. For her, she could hardly get her lips together, and she loved it. So, and often when we've got a patient that is very, very aesthetically aware, if I've got a supportive partner with the patient as well, so her husband Peter, he had a great eye as well. Peter was involved with this, so here he is. And Peter was his hobby is taxidermy. So he used to like set up foxes' teeth and but he seriously had a great eye, but he was really supportive, and he'd look at, he was participating with the first try-in, the second try-in, he was like, you got that just right. So here we've got the video on the screen, the big screen. On my laptop there, I've got her first try-in 1, we've got try-in 2, and then she can have a look in the mirror, and it was great. And she really loved it. So, and that was what we did. So that was our try-in 1, but this is how she finished up. There, trying to mimic that arrangement. In particular, Rowan's really looked at how that upper left 6 sticks out, like this, and the arch forms, quite V-shaped, really. So it's great. And actually, for her, and this is what I quite often do, is I offer 2 dentures to the patient as well. She actually has 2 upper complete dentures that are just like this, and Rowan makes them at the same time, and we can offer that at like 20% of the normal fee because we're making it at the same time. It's quite useful, so that when one breaks, she's got the other one as a spare. It's like a holiday spare, takes it with her all the time. So look at that, that's her massive overjet, anterior open bite, occlusion on the 6 there. So there's actually no contact at all apart from all the way forward, and she functions perfectly well with it. She's got a massive ridge at the top. It really is. It stays in beautifully, but she can function perfectly well because her natural teeth were in that position, or approximately that position. So there. So I just want to end now. I want to just share with you my most difficult denture case that I've ever treated, and I promise you it is the most difficult case ever. Here's Anne. Now, Anne was really unfortunate. In fact, in my practice, I'm increasingly seeing this where patients have had dental implants and they've failed. So she used to have 4 lower implants on a fixed bridge, and all of the implants had failed, and it left all this scar tissue and not very good denture base for the denture to sit on. And so when I saw her at the consultation, and this is at the consultation stage, I just took a video of me just very lightly with my gloved finger just rubbing the lower ridge, just going over the top of it. Just watch her flinch when I'm doing it. This is like, seriously, the lightest pressure. It's almost like I could have blown on it, like, and it would have made a jump. So just watch her flinch. It was like going round there. It was flipping heck. And I was like, no way am I going to be able to make a denture that's going to be comfortable for you at all. It's just, you know, we're on proper Mission Impossible. So I got Rowan to come through, and he coloured in a little chart of where I could actually put pressure. So the green bits are where I could put, you know, reasonable pressure, and then the rest of it, so the green bits are where I can press firmly, and the rest is that just excruciating pain. So, and this is when, you know, I've just got to be so honest with the patient. This is me during my conversation with the patient. I videoed that conversation, and I was like, I'm like dead serious. You know, I don't think we're going to be able to help you with a denture. And I talked it through with Anne and her husband about this. And really, you know, I've got the photo up there, I've got a model of a flat ridge and saying, look, where are we going to put this denture? And I really felt that the best option was going to be 4 lower implants and a screw-in fixed bridge, like an oil rig type approach. But because of her past experience with implants, she's really reluctant. So I just said, look, this is totally ballpark, 30% chance of success here. That's all. And if it doesn't work, I can't refund you the money. It's going to take me time to do this. So, and I think even with 30%, it's always going to be uncomfortable. And she went along with that. She said, look, I want you to have a go. I feel good about this. So we went with it. So I used all the steps that we talked about today, just before. So it's primary impressions with that 2-stage technique, Accudent XD. I did the upper and lower impressions in the same way that I would normally do. I actually used alginate for the lower though instead of zinc oxide, just so it was softer and didn't displace those lower tissues as much. And, you know, wax rim carving using those dentate pictures, you know, really looking at what does she used to look like. And also, and this is, I think this is like massively important with these flat mandibles, is to record centric relation accurately. I've got to get that retruded position recorded. So, and in doing so, I need to use this. I don't use my wax rims at all. It's the central bearing apparatus to record accurately the centric relation contact position. It's brilliant, and it's just so easy to do. So we've got, like here, we've got the definitive models here. We have base plates. This is light cure underneath the wax. It's solid, it sits onto the definitive cast properly. And then we've got these 2 plates waxed onto it. I've got a little pin that I can screw up and down for the occlusal vertical dimension, and then the patient can bite together onto that. And it goes in the mouth like this, nice and parallel. So the only point of contact between the upper and lower jaws is here, just there. And then I use a Chinagraph pencil. I warm up that plate actually in a Bunsen first, so it's hot. And then the Chinagraph just melts onto it, lovely. And it produces a lovely surface for me to scratch out the triangle. So put this back into the mouth and get the patient to really go for it. Forwards and back, forwards and back. The back position is where I want centric relation. And then go side to side. And then I say, right, just go for it anywhere, just move anywhere, go for it. Go for it, Anne. All over. And it's just wonderful. It comes out like this as a triangle. The triangle's often different shapes, but the tip of the triangle is centric relation contact position. So when the patient closes together in that position, we set the teeth up, they'll be evenly biting together. So I put a disc over that with a hole in, right over that, and there's a little screw here, just tighten that up so it's nice and tight, right over the apex of the triangle, back into the mouth, just gently guide it back into the hole so the patient's closed together into that countersink hole, and then using Futard D bite registration material, Futard D, cat and back product, German, it's ACE. It sets nice and solid, but it's not too rigid. And that's it, the setup. Rowan then sets the teeth up. He can actually arrange the teeth appropriately for her. Let's have a look at the finished teeth here. So we've got here, if you look closely, there is a Moloplast B soft lining on this. So this is a silicone soft lining. It's Moloplast B. It's a German product. It's great for these cases. And that is on the base of the lower denture here. And then it's just normally processed everywhere else. But this is Anne's, how she actually turned up with. This is her lower denture. I'm just going to superimpose my denture over the top of it, our denture, Rowan and mine. So it just covers. It's like we use the snowshoe principle, maximise the surface area, you know, so it actually distributes the forces like that. And then this is the fitting surface of the denture. So this is all Moloplast B. It's like resilient soft liner. It's not super soft, but it's resilient. And then when I come to fit it, and this is a great tip when I come to fit dentures. When I try it in, I put it in the patient's mouth. So I've got the new denture here. I've got the lower, and Anne's in the chair. I press down on it. And then I say to Aunt, where's it sore? She'll point to approximately where it is. I take the denture out, and if it's got Moloplast on it, I put Vaseline on the fitting surface, and then a really light-bodied wash of silicone impression material, just like crown and bridge material, over the top, back into the mouth, push it down, and where it shows through, so here, where it was sore, I then use a China graph pencil and just mark on that. And then I just peel off the silicone and then use a burr just to trim away those pencil marks. And then I try it back in, and I do that until it is comfortable. I won't let the patient go out the door until the denture is comfortable. If it's at all sore at the fit appointment, it's going to get flipping sore literally in a few hours' time or a day's time. So that's what I did for her. And this was how she was at the beginning. I just look at the photo here. You can probably see all the sort of issues associated with that denture. That it's too low, it's too far down, too much tooth show. Let's take it back up, lift it up. She's also Class 2 Division 2. She wanted no characterisation of the teeth, and she wanted them a little bit light, but we just set them up like a natural teeth would have been. And that's how she ended up. And with her, I actually saw her for 6 reviews. And as part of the treatment plan, she paid for 6 reviews, but I said any more reviews that would be needed, because I thought it could be an ongoing thing for 6 months potentially, that she'd pay for further reviews. So say she had a 7th review, she'd pay for that. And she finished it at review 6, and I've not seen her again, and she's written a letter saying she's happy with the denture. So I was like, it worked really well with her because she's a nice person and she's reasonable. I've had more difficult cases that are technically easier to do, but that what's up here is more difficult to actually treat. So, to manage. So, and then one other thing, over the past 12 years since I've had the referral practice, and me and Rowan have worked together in this private practice, we've done 239 sets of complete dentures, and none of those patients have come back to see me to request implants after having it done. I'm not saying I don't do implants, because I do, because some patients say, look, I want them right from word go. But the ones that have just had the denture first and say, look, let's see how you get on, none of them yet have come back. I'm sure someone will, but at this point in time, 12 years on, I haven't. So, thank you very much for your attention. It's been really lovely.
Thank you, Dr. Sutton.